Thank you and good morning. My assignment was to discuss clinical insights on urgency learned from treating patients with overactive bladder. So you'll find that a lot of what I say will be complementary to what Professor DeWachter said. There's some facts, some opinions, but I would ask you to sort of erase your memory about urgency, and let's take a trip down urgency lane. These are my disclosures. My trip was paid for by my university, every bit of it. So what do we know about urgency, or basically what do we think we know? Here are the two definitions from 1988 and from 2002, and you can see that they're quite different. One has fear of leakage or pain. I think everybody would agree that pain is really not a part of it. And the other one describes the onset of some sort of sensation, which is defined as a compelling desire to pass urine that's difficult to defer. Now, everybody would agree that it's different. What you feel in overactive bladder is different from what you feel in painful bladder syndrome or bladder pain syndrome or interstitial cystitis, because there really isn't much of a variety of pain associated with it. So what is it, or what do we think it is now? Well, we would agree that it's the hallmark symptom of overactive bladder. It's the driver of overactive bladder, and urgency has a profound effect on the quality of life, however we define it and however patients think about it. Overactive bladder, on the other hand, is a symptom syndrome. Everyone is familiar with the definition, and urgency is the first word, and urgency is the thing that you must have to fit into the overactive bladder category. And I think everyone is basically familiar with this diagram of the spectrum of overactive bladder. So basically, what does urgency do? Well, whatever we define it as and whatever we think it is, it does increase urinary frequency because that either results from urgency or maybe the fear of getting urgency, so-called prophylactic voiding. Urgency derives all these behavioral adaptations that patients adopt in order to either keep from wetting themselves or keep from having to run to the bathroom at an inconvenient time. It precedes urgency urinary incontinence. At night, it sometimes results in nocturia or urgency urinary incontinence. And I think everyone would agree that the successful treatment of what we call urgency results in an improvement of most of the other symptoms that we associate with overactive bladder. This is Chris Chappell's diagram, which I think summarizes very well what people perceive that urgency does. And why is it important? Well, if you actually look back through the literature, you'll see that as far as treating patients with overactive bladder, that if you treat urgency and if you get a good result, that is really more important than the actual result that you get in treating incontinence or frequency or nocturia. And urgency really has the greatest effect on quality of life, and the inability to control urgency appears to be more distressing to patients. This is Karen Coyne's paper from a while ago, than the incontinence itself. So what about the definition? If you ask patients or if you ask your colleagues, well, experts argue about should we have left out the fear of leakage from the first definition, and actually we didn't. If you read Paul's explanation of the current definition, the new definition of urgency only applies to fear of leakage. In other words, we threw out the pain, which everyone agrees with, but if you take the current definition literally, it does imply the fear of leakage. So we didn't eliminate that. Is that what we tell patients? I don't think so. If urgency does not imply the fear of leakage to patients, then what is it? Well, I think that patients think of it as a strong desire to void, maybe with an abrupt onset or maybe not with an abrupt onset, depending on what you think abrupt onset is. I think that most studies on the treatment of urgency don't really seem to distinguish getting rid of the fear of leakage from getting rid of a strong desire to void that occurs fairly frequently. And I think that most patients, in my experience, really judge treatment on how quickly they need to void or how long they can hold it. And the real question is, that I want you to think about during the rest of this talk, does it really matter? If you're going to argue about sudden, Basically you have to ask the question, is urgency dichotomous variable or a continuous variable, which has been spoken about previously? Is it all or none? Are there grades of severity? And does it always end in a void or a leak? Well, again, this is Chris Chappell's diagram that describes why urgency is so difficult to characterize. Is it basically like a light switch, on and off, or do you have it on and do you have varying degrees of sensitivity? Well, my personal feeling from talking to patients is that it really is a phenomenon that can be episodic with no prior urge to void, or it can occur as the final sensation following a gradual buildup of the urge to void. But I think there's a definite point where urge turns into a really compelling desire to void, and that may be what patients think of as urgency. So my feeling is that urgency, yeah, it is episodic, but like a light switch, it can vary in intensity, and that's why people can grade urgency. Now, I'll refer to Jerry's presentation at the AUA, Jerry Blavis, where Jerry presented a study that he had done, 48 patients who had urgency. We never defined urgency, but what he considered to be urgency, and he found that basically this was a continuous variable in 69%, and a dichotomous variable in only 31%. Now, I'm not sure how fast the intensification was, and I'm not sure whether these patients had fear of leaking, and I'm not sure exactly what the definition was. But here's another study to sort of back up that phenomenon. This was a study by Inga, basically where they looked at water loading in 10 patients with overactive bladder versus a prior group of healthy volunteers. And basically what they found was that pressure was experienced by all volunteers in overactive bladder patients, and it gradually builded in intensity and triggered voiding, but it was described as continuous rather than episodic. In the overactive bladder patients, though, urgency appeared as a real intensification of the need to void. Now, there was something peculiar in this paper because it said that urgency appeared suddenly in only 2 patients. But all the overactive bladder patients, when experiencing the need to void, had to run to the toilet. Now that implies to me, if they had to run to the toilet, that maybe it was an intensification of simply this pressure that they get during bladder filling. And you have to ask the question, is this really a play on words? I mean, what are we talking about here? And this is the diagram, basically, of the sensations that these patients felt. And I think that you can agree that basically the diagram on the right, which is the overactive bladder patients, is certainly different than the diagram on the left, which are the normal volunteers. Does urgency always end in a void or a leak? No, because it can be suppressed. That's what behavioral modification does. Can we measure urgency? Well, I think that if we go to measure urgency, you have to translate the definition in an unequivocal way to patients in a form that they can understand. So are the 3 definitions that Marcus Drake and Paul Abrams put in their chapter in Campbell's Urology about how you could possibly describe urgency to patients. And as you can see, basically the second one is really different from the first and the third one because the second one doesn't have anything in it about the fear of leakage. The first and the third one does. So you can measure urgency. You can measure it with so-called objective instruments. You can measure episodes, warning time, etc. The problem with episodes is that episodes really don't account for the patient's ability to defer urination or to delay it. And they don't account for how bad the urgency is and therefore how it affects quality of life. One episode of really severe urgency is probably more troublesome than 3 episodes of mild or easily aborted urgency. Warning time was an interesting parameter. I always asked, are we more interested in the increase in warning time to leakage, which still occurs in a patient, or are we more interested in warning time for those episodes that don't lead to leakage? And the latter has never really been explored, so I'm not sure that trying to explain warning time to a patient is a very worthwhile thing. Urgency-free time interval, I think, was a parameter that was invented basically by studies that couldn't show an increase in warning time. And I have difficulty understanding the significance. Are there subjective instruments that can measure urgency? Well, yeah, take your pick. There are 9 of them, basically, that I counted, and there are probably more. And if you look at these various scales, you'll see that many of the gradations here are not what you would consider urgency, and neither would patients. For instance, 1, 2, and 3 here are probably not urgency. 0, 1, and 2 here are probably not urgency. 1 and 2 here are certainly not urgency, and I'm not sure what 3 is. The urgency perception scale, 1 is certainly not urgency. 2 and 3 probably are. The patient perception of the intensity of urgency scale, again, 1 and 2 are certainly not. 0 and 1 are certainly not. 2 may be, and 3 and 4 certainly are. The urgency perception score, and these are things that you describe to patients because they're the ones that actually have to fill these forms out. Well, 0 is not, 1 is not, 2 may be, 3 yes, 4 yes. And again, the urgency severity scale, nope, 0 is not, 1 is not, 2 maybe, 3 is certainly. The overactive bladder symptom composite score, 0 or 1, no urgency, 2, not really urgency, 3 maybe, 4 definitely, 5 yes. Does treatment affect urgency? Well, this is really what patients are interested in. So yeah, but you have to be very careful when you look at the studies to look at the placebo rate and look especially at the drug placebo ratio. So how well do patients think that we do? Well, this is the first study I think that ever looked at urgency as a separate variable, Freeman study, and this was the change in perception of urgency, the drug placebo ratio, 44% improvement versus 32% improvement. And the change in bladder condition. You say, well, I guess it did work. But take a look at this, because this is very characteristic of the results that we get. So here's an improvement in 12.2% drug versus 2.2% placebo. And yet, look at the numbers, 1.8 to 1.58 on a scale, 1.8 to 1.77. Now, is that really a meaningful difference to a patient? No, it's really not. Here's the numbers with darifenacin, again, very similar. Here are different ways of rating results with solifenacin and placebo, and you can see that the differences are really not that great. So when you speak to patients about correcting urgency, the patients really don't think that we do that well. And again, here's fesoterodine. This is median change in episodes for the 2 doses of Feso, 16.7 and 18.6 versus 7.7% placebo. And you say, well, actually, that's pretty good because that's twice as much. Then look at the numbers. 9.2 episodes to 5.2 versus 9.2 to 6.2. You think that's really a difference? I don't. So the real question then is what do these results mean to a patient? And the conclusion you have to come to is based on the persistence and continuation rate for all the drugs, not very much. So what have I learned? Well, urgency is the premier symptom of overactive bladder. It does drive the other symptoms. It is difficult to define because should we include fear of leakage? I don't think patients include that. Is it of sudden onset? And if it's of sudden onset, is it dichotomous or is it continuous with just an intensification at the end? It's very difficult to communicate this to patients, and therefore it's very difficult to measure in a reliable and valid method. Successful treatment of urgency improves the other symptoms of overactive bladder, and patients say that they're better. But since improvement in overall symptoms and quality of life are what seem to matter most to the patient and not the definition of improvement in some vague concept that we call urgency, I think we've gone way overboard in trying to quantitate urgency. So this is a quote that I published 10 years ago. Urgency forms the cornerstone of the definition of a condition that affects up to 17% of the adult population, and yet we know little or nothing about its pathophysiology, what urodynamic parameters are related to it, or how to properly measure it. I think that patients don't really care whether the sensation to void, which can't be ignored, if you use that as a sort of definition, develops suddenly or at the end of a continuum of sensation. And I think they are far less concerned with the precise definition of urgency than we are. The general evaluation of therapy is what's most important to them. So something like this scale for an individual patient, you can't use it for a group of patients, same thing with this one, Because if you used it for a group, you come out with a change of 3.2 to 2.9. Well, what does that mean? But for an individual patient, I think a score like this is significant. So if they go from 5 to 3, I think that's a definite improvement, and they regard it as a definite improvement. Or what I do is simply ask the patient, do you feel better, and do you want to stay on the treatment? To me, that's what I've learned about treating urgency, is this is what's really important to the patient, and not the definition of this concept that even we can't define. Thank you.